Perthes disease. And it's titled as such because even after 100 years of knowing about what this condition is, we have not made a lot of progress in terms of how to treat this. And kids still suffer, and we don't have a lot of definitive answers for this disease. So unfortunately, it's still a mystery to us. So we'll go on with that. So we'll give credit where credit is due. Legg-Calvé-Perthes disease is actually, there are multiple physicians who initially described this condition: Arthur Legg, Jacques Calvé, and Georges Perthes. And also Waldenstrom classified this as well radiographically. I'm just naming it Perthes just for shorthand, but all of these physicians deserve credit for initially describing the disease in 1910. So what is Perthes disease? Perthes disease is a childhood avascular necrosis of the hip that ultimately leads to some, basically a resorption process of the avascular bone and subsequent remodeling of the hip. And the way that the remodeling occurs is how the function is going to end up. So sometimes the remodeling ends up well, and sometimes the remodeling ends up poor. And then that's how you're going to have a difference as a result. And it's really difficult to tell who's going to go in which direction for Perthes disease. Typically, the age of onset is 4 to 8 years old, a lot more common in boys than girls. There seems to be a racial predilection for more Caucasian rather than East Asian and African. And the incidence for this disease is approximately 1 in 10,000. And you can see this plot here, and the age distribution is in kids, younger kids. And by the time the children reach adolescence, this is not much of a very common disease. And perhaps the theory behind this is because the blood vessel to the hip changes throughout time. The perfusion to the epiphysis is mostly lateral epiphyseal artery initially during the skeletal immaturity, but that changes as the children reach skeletal maturity. So maybe perhaps that has something to do with the pathology or pathophysiology of the disease. So initially, children present with limping, but they're very well appearing. They're trying to run, they're still trying to play. Mild limping that's worse with activity and improves with rest. The pain can be anywhere from the hip to the knee. And just to remind all the residents that children often complain of knee pain when they have hip pathology, and this is one condition that can present that way as well. And when you examine them, they generally have inflammation or stiffness of the hip. So they have limited abduction of the hip and limited internal rotation of the hip on examination. And over the course of the disease, typically the limp does improve with time during the healing process. It takes a couple of years for this to improve. So what's the big concern for Perthes disease? So like I said, there's a remodeling process that occurs after the initial insult. But the remodeling process can be really bad too. Sometimes you get a very aspherical hip. You get this oval-shaped hip. You get a growth disturbance of the proximal femoral physis. So you get trochanteric overgrowth. It leads to impingement of the hip. And ultimately, for those that remodel poorly, you can have very early hip arthritis and the need for a total hip arthroplasty, even in your 20s or sometimes even younger. So the goal really is to prevent debilitating hip arthritis, give them back some function without arthroplasty, and prevent loss of early hip function. The description of disease process, there's very limited histological studies. As you can see, that's pretty hard to get samples from live children for pathological specimens. But from the limited data that we do have from human specimens, we noticed that there is a particular disease process that occurs, and Catterall summarizes very nicely. Initially, the necrosis occurs, and microscopically you can see from the physis to the subchondral plate, so essentially an epiphyseal necrosis, not so much below the physis. And after that, the resorption of this necrotic bone occurs with high osteoclastic activity. Once this bone is resorbed, it's filled in with vascular granulation tissue, and that ultimately heals both from appositional healing as well as replacement of the tissue with bone and vascular tissue, and with new bone eventually. But during this process, you can see that with osteoclastic resorption of this necrotic bone, you can have flattening of the femoral head, and that's where we think that potentially this leads to femoral head deformity as well. the Waldenstern classification is really important to recognize because this is the radiographic evolution of the disease. And this kind of correlates to what we know from a histological perspective as well. Initially, the first phase of Perthes is the avascular phase. So what that looks like on X-rays is a sclerosis of the hip. You can see a little bit of darkening of the epiphysis here, or whitening of the epiphysis. And ultimately, this leads to during the resorption phase where the osteoclasts are very active. You can see that the subchondral bone is resorbing. In many pediatric radiographs, we don't see all of what's happening because the cartilage is not visible, but we see that the subchondral bone is resorbing, and it's basically the osteoclasts are very active. And after this resorption or fragmentation phase, we see that there's a reparative process or reossification where this cartilage enlarge that we can't see is being replaced by bone. And ultimately, what we end up is a hip that can look very good or look very bad, depending on how that remodeling process occurred. So the basic unifying principle or mechanism for the Perthes disease is the underlying vascular insult to the hip. One very important study from Japan, they did angiography for children who had Perthes disease for the medial femoral circumflex artery. And you can certainly see in most of these patients, they had this distinct pathological lesion where they had this flow void of this lateral epiphyseal artery. So on this image on the left, this is the medial femoral circumflex artery coming up and arising to the lateral epiphyseal artery. However, in these kids with Perthes, many of these children had the MFCA flow suddenly stop at the where the lateral epiphyseal artery should be. So potentially this is the underlying pathologic reason why these children get Perthes disease, but we still don't know why this happens. Why do these children get this avascular lesion? Even though we understand that this is potentially the cause, we don't understand what causes this flow void. So there are some associations that people have looked at. People have looked at smoking status. So Perthes disease was highly associated with maternal smoking status in utero. Also, interestingly, socioeconomic status seems to be important. So in this table down on the bottom here, this is a socioeconomic deprivation score, 1 being the worst and 5 being the least deprived. And we can see that those children who are the least in the worst socioeconomic status tended to have higher incidence of Perthes disease as well. So that's an interesting phenomenon as well. And people also have looked at, do these children have hypercoagulable factors that leads to this initial insult or vascular insult? And there has been some association that some of these children have higher incidence of factor V Leiden, factor VIII levels, differences in protein CNS serum levels compared to the normal population. But these associations are, and you can see that the odds ratio is very, very high if you have more than 2 of these risk factors for developing Perthes disease. But then everybody else, there's so many things that were looked at for Perthes disease in association with ADHD, Perthes disease with hyperactivity, low birth weight, obesity, and so on. So I think there really isn't a clear unifying underlying reason why these kids get a avascular insult. So I think we still say, similar to everything we don't know about in medicine, it's multifactorial. Just like in adolescent idiopathic scoliosis, we don't know. So we just do a cop-out saying it's multifactorial. So similar in Perthes disease, we don't know. There's some associations that may be some clues, but unfortunately, we don't ever have the opportunity to see Perthes disease before it happens. They always present after it happens. So animal studies is what we turn to try to understand why this happens, what causes it, and what is the actual disease process and evolution of Perthes disease. This is a very interesting study. These are immature rats, so just like immature humans, simulating the study group. Basically, in one of the groups, the rats were forced to drink water from a very high cage. So they have to really stand up to drink water. And in the other group, there was a low cage, kind of a normal height that the rats don't really have to stand up. And we saw that the rats who had to stand up a lot tended to develop osteonecrosis of that hip or avascular necrosis of that hip. So this suggests that potentially Perthes disease may be due to excessive or repetitive trauma to the lateral epiphyseal arteries. So maybe there is a link between these very hyper kids who are extremely active to develop Perthes disease. So this is one theory, that it's excessive mechanical deformation of the lateral epiphyseal artery that leads to this avascular necrosis. We also know from animal studies that once Perthes occurs, so this is a piglet model, we know that the mechanical properties of the cartilage and the bone of the epiphysis is extremely weak. We can see that at 2 weeks, 4 weeks, 8 weeks post-infarct, that all of this bone is significantly weaker than the contralateral normal side or the non-infarcted side. So in an immature AVN, we can see that clearly that this is at risk for collapse and mechanical deformation after the disease process occurs. We also know from animal studies a little bit more about the repair process. So in this study, ligature was applied to the femoral neck, similar to, so basically if there's a lateral epiphyseal artery that would just cut off circulation to the hip. And basically I was left there and seeing what happens. After 48 hours, we can see that there's complete avascular flow to the femoral head in these piglets. But even with the ligature left on there is transosseous and transcartilaginous revascularization that occurs in these immature hips or immature pig hips that leads to ultimately remodeling and reossification of the femoral head. And that's the difference between children and adults, I think, is that at some point towards in late adolescence or during adolescence, that this possibility to traverse the femoral head through the cartilage onlodge is lost. So when we see adult avascular necrosis, there's really no remodeling phase. It's basically flattening and destruction. But in children, if we have avascular necrosis, there is some sort of ability to repair this process. So what is the natural history and of this disease if left untreated? So one study looked at 36 patients, and at a mean age of 45 years old, when these children with Perthes disease were looked at, most of them were doing fine. Most of them, over 80% of them had Iowa hip score of over 80, and only 8% needed a total hip arthroplasty, which is not bad for this kind of a condition. However, if you look at the same patients 10 years later, mean age 55 years old, they're still pretty young. 55 is not an old adult. 40% of these patients ultimately ended up getting total hip arthroplasty. So ultimately, we see that there's some point during time in the 5th decade that this really takes a turn and develops debilitating arthritis much, much earlier than the general population for osteoarthritis. And we want to know who does poorly and who does well. And Stolberg came up with this classification from 1 through 5, and this is really important to recognize because I'm going to reference it throughout the talk. Stolberg 1 basically looks like a normal hip, and Stolberg 5 is a flat, aspherical, incongruous hip. And basically 1 through 5, 3 is kind of in the middle, it's ovoid, and it goes from worse from 1 through 5. And this has been prognostic for developing osteoarthritis. So Froberg in one study had a 47-year follow-up for Perthes patients. And we can see that those with Stolberg class 1s and 2s that are basically spherical hips, 1s and 2s, as you can see here, after 47-year follow-up, only 2% of those patients had osteoarthritis. But those with Stolberg class 3, 4s, and 5s, oval hips to those who are flat, many of these patients, 25% of these patients developed osteoarthritis. And other studies have confirmed this finding as well. This is another study that had a 22-year follow-up for non-operatively treated Perthes disease. We can see that the Stolberg's 3s, 4s, and 5s have 61 to 62% of rates of radiographic changes, Tonus type 2 or grade 2 or grade 3 at 22-year follow-up. And the type 1s and 2s, Stolberg type 1s and 2s, have much, much lower rates of radiographic changes of osteoarthritis. So it seems like the more spherical the hip is, the better that these patients ultimately do as adults without the need for total hip arthroplasty. But what about function? Does the Stolberg classification correlate with function? And in general, it does. We can see that For Stolberg type 1s and 2s, the non-arthritic hip score is much higher. Higher is better for 1s and 2s, but the 3s, 4s, and 5s have much lower scores for patient-reported outcomes. But it's also important that even though you have a spherical outcome, Stolberg 1 and 2, many of these patients still have experienced some pain to that hip. So it's still not a perfect result, even though we get a spherical hip. So we know that sphericity of the hip is important, as Stolberg's classification taught us, and multiple follow-up studies as well. But Stolberg, we can't classify into Stolberg until they're skeletally mature. So what if this child presents to you in your office at 5 or 6 years old? How do we counsel them? How bad are they going to be when the time that they're adults, or are they going to have a good result? So we need a better classification system when they're younger. To understand how they'll do when they're older. So this is where Herring comes in. This is the other classification you should know. The Herring classification is a lateral pillar classification. Herring type A, what we're looking at is this lateral 1/3 of the epiphysis here, where my mouse cursor is. In Herring type A, there is no collapse of the lateral pillar. So sometimes you could have a central necrosis or central Perthes disease, but the lateral pillar is preserved. In Herring type B, you have a necrosis, but over 50% of the lateral pillars is intact. So the height of 50% intact. And type C, less than 50% is intact. So on this example, radiograph example on the left, I would call this perhaps a B. Compared to the contralateral epiphysis, it's about 50%, maybe slightly over a little 50% remaining, and I'll call that a B. So, but the problem with this classification is that this is only classifiable during the fragmentation stage of the disease. As we know, the initial stage of the disease, we only have sclerosis radiographically. So the problem with this is that you have to wait about 8 or 9 months to understand where this child lies in their prognosis. And if you could have intervened in that first 9 months before knowing the Herring classification, you lost that time to do so. So that's the one fault of classifying in Perthes disease, because the Perthes is an evolving process, and we really still don't know how bad it's going to be when it initially presents. And this is a classification based on the fragmentation stage. So this has been shown in general that if you have Herring group A or lateral pillar group A, where the whole lateral pillar is intact, none of these patients had a Stolberg classification 3 or 4 or really bad hips at the time of skeletal maturity. But those with group C, where less than 50% of the lateral pillar height remained, you can see the trend towards worse radiographic outcomes at skeletal maturity. And we can also see that the reossification stage in those with lateral pillar type C, less than 50% remaining, takes a lot longer. That means the extent of osteonecrosis to that epiphysis was probably a lot more. It takes a lot longer to reossify that hip. So lateral pillar C seems to be a very bad prognosis. What about other things? Age is also extremely important. We know from multiple studies that age is a protective factor for developing poor radiographic outcomes in Perthes disease. In this table, you can see age under 6 on the left, age over 6 on the right, and you can see in general that those with under 6 have the incidence of poor results with those under 6 is much lower than those with age over 6 at the onset of disease. So age tends to be protective in developing poor outcomes as well. In one study, when you looked at only younger age, less than 6 years old, we want to know, do they all do well? And that's not really the case either. Although they do better than older kids, those kids from age 4 to 6 who had lateral pillar BC order or type C, meaning more necrosis to the femoral head, based on the Herring classification, had only a 43% probability, a 0.43 probability of having a good radiographic Stolberg type 1 or type 2 outcome. So age is protective, but if you have a lot of osteonecrosis to the hip, it's not fully protective. That also means you could have a young patient with a bad outcome. So both age and lateral pillar classification are extremely important for the prognosis for eventual radiographic outcome. So what do we know so far from animal studies, human studies, natural history studies? So in summary, we know Perthes is avascular necrosis. We don't clearly know what initially causes the vascular insult, but there's some vascular insult. Immature hips can remodel even though they get AVN. That's why perhaps the really young kids can do a little bit better than the older kids because they have more chance to remodel. And we saw in animal studies that immature, totally avascular epiphysis has the ability to reform blood vessel to the cartilaginous onlage, unlike in adults. We also know that the bone in Perthes is very weak, so it can deform very easily. And the rounder or more spherical the hip is, the better the result ultimately. So how can orthopedic surgeons intervene with all this information? So really the concept of treatment is prevent deformity. So we know that Perthes hips are weak during the fragmentation stage when the bone is being resorbed. So somehow we can intervene there. And so over 100 years of knowing about this disease, basically the treatment goal for orthopedic surgeons is so simple. It's basically make the hip round. A round hip is good. And again, the only real ways we are doing this right now is restricting activity or weight bearing, trying to prevent deformity of the hip where the bone is really weak and fragmented. Try to prevent hip contractures. And there's this theory of containment where in Perthes disease, the hip tends to extrude laterally due to inflammation and remodeling. And if you, just like as we know in hip dysplasia, if you have too much edge loading of the hip on the acetabulum, you can cause deformity or excess contact force on the hip. So we want to contain the hip fully in the acetabulum so that when it remodels to the shape of the acetabulum, it's a sphere. So that's the principle of containment in Perthes disease. So we'll go over non-surgical treatment. How do we contain this hip into the socket so it remains round and that doesn't deform? So this was popular back in the day. And if you can read this underlined portion, this is a study that was published in 1977 for about 17-year follow-up. So that means these kids are treated in their 50s and 60s. Basically, what these kids had to go through was that they were hospitalized for years and basically were in traction for average 11 months, non-weight bearing traction for 11 months, and they were in non-weight bearing plaster casts for 15 months on average. So that's 26 months of not not weight bearing and living in a hospital to take care of Perthes. That's pretty extreme. I don't think there's any way any kid's going to be able to do that here in the United States, this kind of treatment. And the results basically show that compared to the controls at that time, they generally had more favorable results. The incidence of poor results was only 9% compared to 24% with this kind of aggressive hospitalization of these children. Keep them in traction, don't let them walk. So this is kind of the concept of, okay, let's not deform the hip when it's weak and until it remodels, and let's see how they do. But obviously there's not a lot of buy-in for this kind of treatment because of how much potential psychological harm this can do to a child at that age with over 2 years of bed rest. And this study may have some flaws as well. The mean age of onset was 5.5 years, which is a generally younger patient population. So they may have a little bit skewed towards better results as well in this group. So because this kind of treatment hasn't really taken off because of how intensive and how maybe potentially traumatic it is for the child, then people started looking at certain kinds of bracing. How can you contain the hips by abducting the hips into the socket using a brace, and they can just walk with this brace? And the problems with these studies, there's no control group for many of these studies, and there's no definitive definitive answer saying, hey, this really, really does work in helping improve the outcome of Perthes disease. I think there's a lot of mixed results with weight-bearing braces. So this really hasn't really taken off as standard of care, but some people certainly still do this for treatment of Perthes disease. So let's talk about surgical treatment. So again, our theory is how do we contain the hip to prevent edge loading or deformation, and how do we prevent deformity of the hip with weight bearing? So there's only several strategies we can do. To contain the hip, you can do a proximal femoral varus osteotomy, or you can do some sort of pelvic osteotomy, whether that be a Salter or triple innominate osteotomy to cover the acetabulum. More commonly, the varus osteotomy is the more common solution that is offered for these kids. And you can see an example here. This child had Perthes disease on the right hip, underwent varus osteotomy to contain the hip, and because you can see the extrusion here. and that can lead to deformity of the hip, and certainly had a reasonable result at 4-year follow-up as far as lack of radiographic changes there. And then how do we force these kids not to weight bear surgically? And this is where the concept of hip distraction comes in. Some centers are placing external fixators across the hip joint from the pelvis to the femur and distracting the hip so that when the child weight bears, they weight bear through the frame and there's no contact force through the hip and through the acetabulum. That's one treatment that some people are doing as well. So there are two landmark studies that everybody should know about in the treatment of Perthes disease, because this is how most people treat Perthes disease. And when I was a resident, I was very confused by this because it's very specific as to like who gets offered surgery, and it didn't really make a lot of sense, but I'll try to explain here. In this study, this is a 345 hip multi-center study for Perthes disease, and they evaluated the outcomes of 5 different treatment options. No treatment, brace treatment, where the hips are abducted, range of motion exercises only, femoral osteotomy, or pelvic osteotomy, and they evaluated the radiographic outcomes at skeletal maturity. When they look at all the different types of non-operative treatment groups, bracing, range of motion exercises, they saw that there's really no difference in outcome of the Stolberg classification amongst all these different types of non-surgical groups. So there wasn't really clarity as to whether bracing really does help compared to just leaving the child not much or restrict their activities. In the operative treatment group, we see that on this diagram or this table on the right, this is the main result from this study. In general, the children who are lateral pillar A, meaning the entire lateral epiphysis was intact in the fragmentation stage, all of them had a good outcome, or most of them had a good outcome regardless of the treatment. Whether you did surgery or not, these children had a good outcome. So surgery did not seem to help this group at all. You could just have them do range of motion exercise and then potentially have a good result. Lateral pillar C, remember, there's more necrosis to the hip. There's over less than 50% of the lateral epiphysis is intact. And we can see that regardless of what you did, whether you didn't do surgery or whether you did surgery, these children did poorly. So it seems like there's no benefit of surgery in those kids who are severely affected by avascular necrosis. Seems like, though, those who are in between, those who have maybe approximately 50% of the lateral pillar intact, so lateral pillar B or BC border, if you are young, it seems to be protective. Seems like surgery didn't really help at all if you're under 8 years old compared to non-surgery in these groups. However, if you're older than 8 years old, surgery had a benefit compared to non-surgical groups for this particular group. So I can see how this is very confusing for residents because it's very specific as to who potentially benefits from surgery. So in general, the way to think about this is if the avascular necrosis is not that bad, they're going to do fine without surgery. If it's really bad, they're going to do poorly regardless of what you do. But the in-betweeners, and they're a little bit older, maybe those can benefit from surgery. And you can see in this diagram here that lateral pillar C, those who had less than 50% intact lateral pillar at fragmentation stage, regardless of age, generally only 20% or less had a good Stolberg result at skeletal maturity. So the extent of avascular necrosis seems to be very predictive of outcomes as well, regardless of what age it presents in. Another landmark study published by WIG had 325 cases, and they similarly presented the results, and the way they presented it was age group over 6 and under 6 years old. And in general, we can see a similar outcome that osteotomy, femoral osteotomy, generally tends to have a higher rate of Stolberg, lower Stolberg group or better outcome compared to orthosis or physical therapy. But look at the numbers here. If you have a 43% rate of a good outcome for femoral osteotomy compared to 20 to 33%, it's not a home run win. It's really just a little bit better than non-surgical treatment. So surgery seems to have some modest benefit, but not a huge benefit. So, but if you look at the under 6 years group, it seems like the PT, orthosis, and osteotomy group, they all are similar in their rates of outcomes, regardless of what you do for these hips. So what do we learn from these studies? It seems like older patients may benefit from surgery, depending on how much avascular necrosis they have. However, the treatment effect is relatively modest. There's Dr. Little published on the number needed to treat for having a good outcome. So you need to perform 7 femoral osteotomies to have one good outcome compared to non-surgical treatment. So again, I wish this was a much higher. I wish this was 1 and 2, but we can see that the treatment of the surgical treatment has modest benefit. So we talked about earlier that the problem with the Herring classification is that we can't predict the prognosis until they reach their fragmentation stage of disease. This is really pretty late in the disease. So what if a child comes into your office limping and you see the sclerosis on x-ray and suspect early Perthes disease? And we know that in the fragmentation stage of the disease that the bone is really weak. So if we can contain the hip before fragmentation stage, then that's probably the most beneficial time from a mechanical perspective to remodel that hip into a sphere. However, we lost time there. So how do we predict who's going to become a lateral pillar B or C? So what we're doing these days is a perfusion MRI. A perfusion MRI is a T1 post-contrasted MRI with a T1 pre-contrasted subtracted. And the differences between the two, it shows you how much of that bone is avascular. And you can quantify this with software called HipVasc. And in this example here, we can see that the very dark blue is avascular. And this hip was quantified to be 60% avascular. And basically, this is predictive of a lateral pillar C result as well. So here is based on preliminary data from MRI, perfusion MRI, we can see that in general, the higher the percent perfusion, it does tend to predict the lateral pillar classification. So if you have 90% plus perfusion of the hip on MRI, we see that these generally end up being lateral pillar A. If you have somewhere between 40 to 75% perfusion on the MRI, these tend to be lateral pillar B. And if you have 50% or less perfusion on the MRI, these tend to do poorly or lateral pillar C. So this is one way we can predict before waiting for fragmentation stage on x-rays to say, hey, this child's going to do well or poorly, or they're going to fall into one of these groups that may benefit from surgery. So the next steps for perfusion MRI is, because perfusion MRI is very quantitative, it gives you a number, from 1 to 100, 0 to 100, as opposed to the lateral pillar classification A, B, or C. Is there a direct correlation between the amount of avascular bone and final outcomes? And I'm sure we can study that within the next few years as to if there's a good correlation with this modality. So let's do a case example to unify all these confusing concepts. This is one of my cases, is an 8-year-old male who had mild intermittent limping, presented, as you can see on the left hip in the early stage of Perthes. It's not significantly fragmented, but it's sclerotic epiphysis on the left. Like we said before, the Herring classification is not classifiable in this stage because it's not fragmented. How do we give this child some prognostic indicators? He clearly is at the right age for potentially a benefit from surgery, as we knew from those 2 landmark studies just presented. So we got a perfusion MRI. This was quantified to be approximately 40% avascular, 60% perfused. So based on what I also presented previously, this would put us in the range of a lateral pillar B result. And based on the data from Dr. Herring study, lateral pillar B over 8 years old, this is the perfect candidate for surgery based on their study. So this child underwent proximal femoral varus osteotomy to contain the hip totally in the acetabulum. And ultimately, this is just 2-year follow-up. Obviously not skeletal mature yet, but my prediction is going to be a Stolberg type 2, nearly spherical type of result for him, which is overall in the good range. So as you can see how we think through this Perthes disease, this is one case that we, based on the available literature, thought was a reasonable candidate for surgery. So let's just talk about the recent updates for Perthes disease. how do we improve our understanding of this disease process? Because we don't really have really good outcomes with surgery. It's just modest benefits. So we have to see, is there anything else we can do for this patient population? We know from basic science that rank ligand and rank interactions are really important for activating osteoclasts. And if you inhibit rank ligand with osteoprotegrin or some sort of antibody, potentially that can decrease the activation of osteoclastic activity. We know osteoclastic activity is really key in Perthes disease, where it resorbs all the subchondral dead bone. And in one study, again, the piglet model of Perthes disease, we saw that osteoprotegrin injection subcutaneously over an 8-week course compared to saline led to significantly improved appearance of the femoral head. There's not significant amount of deformity. The maintenance of the lateral pillar, or I'm sorry, the maintenance of the femoral head ossific portion was well maintained. So this is very promising, because potentially if we have some sort of biologic solution to potentially hijack the pathway and prevent some sort of mechanical deformation of the hip. We also know that Perthes disease, there's a lot of inflammation that happens because these kids come in with a lot of stiffness of the hip when they present. So there's some synovitis that occurs in the hip. One study looked at an assay of what kind of factors or cytokines are in this synovial fluid, and they noticed that interleukin-6 was very, very elevated in the synovial fluid of Perthes disease compared to the control group. We know that interleukin-6 has a pro-catabolic effect on bone metabolism and potentially also activating osteoclasts as well. So in one study as well, in a piglet or immature pig hip model, we had an interleukin-6 antibody compared to no interleukin-6 antibody injection. And ultimately, the overall global volume of those who had this anti-inflammatory treatment was much improved in their femoral head epiphysis compared to those who did not have this anti-inflammatory treatment. So in future directions, I think the treatment of Perthes disease, a lot of it is not necessarily surgical. I think we have to really understand what the disease process, how the disease process occurs in order to hijack this process and prevent significant deformity where they need hip replacement early on in their life. So I think biologics is probably the key in the future, and I think more research is coming along in this way. So what about some other things recently? So we know that there wasn't a lot of traction for non-surgical treatment, such as bracing or really putting him in bed rest. And we even saw that the Herring study showed that there's no difference in outcomes in multiple non-operative treatments, such as range of motion exercises only and bracing. So really nobody knows what to do from a non-surgical standpoint. But this was a recent study by Dr. Schenecker at WashU St. Louis, who had a very, very strict, rigid protocol on the way he treats his Perthes patients. And at his center, apparently they do not do surgical containment. They do all non-surgical containment with bracing. And he published his results not too long ago. And his indications were if hips had less than 25 degrees of abduction and extension and they had Perthes disease, he would put on a weight-bearing abduction cast for 6 weeks to calm that inflammation and stretch out the adductors, and ultimately change them over to an abduction orthosis where they can weight bear at home with a very strict protocol of being worn over 20 hours a day. And on average, these kids wore this for over 13 months. And when he published his results, we saw some very promising results. And I think it's important that maybe perseverance is key. If you have a strict protocol and it's adhered to, maybe that this does work, just like bracing in idiopathic scoliosis. So he published his results, and he saw that non-surgical containment, when rigorously adhered to, even those who had a lateral pillar C classification, a very avascular hip, and over 8 years old, almost 70% of these patients had a Stolbrook type 1 or 2 hip. And this is remarkable. Remember, we saw in the Herring study or the previous studies that 20% or less had this result. So there's something to be said that perhaps there are ways to do things without having to do surgery in these kids, as long as we know how to do it. So maybe this is some food for thought for the resurgence of non-surgical treatment as well. also is non-weight bearing back in style. We know from animal studies that in this study of a piglet model, again, avascular necrosis is induced for these immature pigs, and they ultimately had a amputation of that leg to simulate non-weight bearing compared to some other pigs who did not have amputation. You can clearly see that those who were forced to non-weight bearing ultimately had a much better shape of the femoral head than those who were weight bearing. So we clearly see that weight bearing has some negative effects to deform the femoral head. But how do we make a human kid not weight bear for years? That's really, really difficult. So in modern times, some centers are doing this where they put a hinge distraction external fixator on the hip, essentially to force weight bearing of the hip to allow this to remodel. But the results for this treatment, again, are kind of mixed. Some centers are really taken off with this, some are not so sure. There still seems to be a very, very high rate of complications with this treatment, mainly due to pin site infection. Remember, this fixator stays on for many months, and you know, it's hard to justify that kind of risk compared to based on the available literature that we have. So I think more is coming out on this type of treatment. There's some centers who are having buy-in on this. I haven't done any of mine of this personally, but I'm waiting in to see if this really does help. So OHSU has been a part of this International Perthes Study Group for the past several years, and I think it's exciting that we are contributing patients to the study group. What we are working on at the current moment is we want to see the surgery help people from age 6 to 8. We know that there's some benefit in over 8, and we know that under 6, there's not a lot of benefit. So we're trying to define that middle age group, and we're collecting data for that right now. We also want to see how important is non-weight bearing for over 8 years old. So some people only do 6 weeks of non-weight bearing after surgery. Some people do 6 months of non-weight bearing. Is there any benefit to preventing mechanical deformation for a strict non-weight bearing protocol? And we really want to see if that helps as well. We're also collecting data on adults and on surveying adults as to how they're doing with Perthes. And we generally see they do pretty bad. You know, I think some of these patient-reported outcome measures may not capture how horribly some of these patients do as adults, and maybe they're in a lot more pain than the need for total hip arthroplasty can suggest, or the rate of total hip arthroplasty can suggest. So overall, I think that's where we all are with Perthes disease. Unfortunately, it's an extremely depressing condition because we don't have a clear treatment option that's much, much more superior than the other. I wish we did, but I think we are continuing to look for answers. And I'll take any questions.
So Scott, this is Matthew Halsey. I was wondering how did they with the Schoenecker study? I mean, it's pretty exciting and everything, but I was wondering if he had some way of measuring how much the kids were actually wearing the brace, or if they were just relying on a diary, or how did they figure it out? Because
Yeah,
I'm
right.
sure I believe it.
Yeah, I agree. Yeah, I just like in the AIS, you know, they didn't have some sort of hip compliance monitor. It was just protocol. But it's hard to believe because it's so different from the rest of the literature. I agree, but it's some food for thought.
Dr. Yang, this is Dr. Freese. I was just wondering, is anyone looking at both using biologics, the OPG perhaps, or bisphosphonate along with bracing? I'm just wondering if you could speed up the biology and get them out of the brace faster, because
Yeah, good question. I think the problem with bisphosphonate or OPG injection is that it's systemic. And in general, in growing children, it's, you know, with just isolated Perthes disease, you're going to have a lot more side effects with bisphosphonate use. OPG similarly, unfortunately, it's hard to target just the hip. I think the next study is to see if there's a way to locally administer some of these drugs to the femoral head. But the OPG will affect the growth plate on the rest of the body as well if you give it systemically.
Why not just inject the hip with it?
Yeah, that's a good question. The animal studies are being conducted at the TSRH with that, I think. But I don't know. I think it's a long ways away from trying it on humans for safety reasons. Anybody else? I mean, any of the arthroplasty faculty see, I mean, is it difficult to treat these patients ultimately when they're an adult?
Hey, Scott, this is Tom Huff. I would say it's not, it's not terribly difficult to treat them surgically. It just tends to be such a young patient population. And I would also say that, I appreciated that you had taken the hardware out of your case example, because sometimes, that sort of conversion can certainly make it more difficult. But I think in my practice, on average, these patients do really well. There's usually some kind of leg length discrepancy you have to deal with and some level of dysplasia, but they tend to recover very well. And it's just a question of how long it lasts.
Mm-hmm. All right. I guess that's it for questions, but email me if you have them, and have a good day.